Good. So it gives me great pleasure to introduce a man that really does not need any introduction. Ahmed is a giant in the field of glaucoma and has his own school of glaucoma and has invested an enormous amount of his life teaching. Ahmed, please.
Tariq, thank you very much for this wonderful introduction. This is actually too much for me. Thank you very much. Thank you to Gamgoom and RM. And I'm happy to work with my friend Keith Barton. So the topic of today is gluco-COVID when the pressure is more than 19. Just we wanted to share together what happened when we have patients which is his intraocular pressure is greater than 19, and actually we have nothing to disclose related to the talk, unfortunately, of course. And just a short story about the COVID in Egypt. On the 12th of January, the WHO announced the new coronavirus responsible for COVID-19, and the report to the WHO was on the last day of the year 2019. Then on 14th of February, it was the announcement by the Egyptian authority that the first case to be diagnosed at the Cairo International Airport involving a Chinese person. And then on the 8th of March, it was report about the first German fatality and the first fatality generally in Egypt, and that was in Hurghada. And afterwards, the authority have decided a partial lockdown and a partial curfew starting from March 24th till the moment. Then on March 27, the American Academy of Ophthalmology announced a list of urgent and emergent ophthalmic procedures. I will just pick up what's related to glaucoma. In relation to cataract surgery, when the lens is causing a secondary glaucoma or angle closure glaucoma, you can do trabeculectomy or implants when the pressure is catastrophically high or rapid progression of glaucoma or uncontrolled primary and secondary glaucoma. You can go for diode transscleral cyclophotocoagulation with uncontrolled glaucoma or absolute glaucoma with painful blind eye. You can implant a drainage device when the pressure is very high and the glaucoma is progressive. And you can also remove the drainage implants in cases of mishaps of endophthalmitis, corneal touch, corneal decompensation, or exposed tube. And then you can proceed for surgery for the kids when the pressure is high and threatening the vision. Now, basically in the private practice, as long as we are in a state of partial lockdown, and then we have set some goals for our service, which is basically the safety of the staff and patients. And then we wanted to maintain the glaucoma service for the patient's interest under strict conditions. And we have those objectives. We supported the available telemedicine, and then we cut down the number of patients, and we shortened the waiting time as much as we can with ultra-speed management of the elderly and risky patients and managing dangerous levels of intraocular pressure. And we focused basically on non-invasive technology as a good option in this era. Definitely, the personal protective equipments were everywhere to the staff, to the doctors, and also applied to the patients. We have the shields, we have the masks, we have the protective glasses. We clean the center every day like an OR. So we worked like two independent teams, team responsible for a sterilization of everything and team responsible for dealing with the patients. And again, distancing as recommended in this era. Now, recently, the American Academy of Ophthalmology conducted a survey regarding the patient's volume during the era of COVID as an introduction to the reopening. And it was found that 95% of the practices are seeing 25% or less of their pre-COVID patient volume. Now, what I have noticed in our situation is like that. In March, which was just the beginning of the era in Egypt, and then we had a volume of patients like 25% of the pre-COVID period, and then the curve seemed to go up. So by April, we have reached like 40 to 50%, and then with May, now we are 50 to 60%. So it seems that like a spontaneous reopening of the service is happening. Now, when I looked at our patients, it was easy to just divide them into two groups, but the division is not very clear because there are some period which is intermediate here. The patients could be COVID worried in the first place, or the patient could be glaucoma worried on the first place. Definitely, there is a zone which the patients are both COVID worried and glaucoma worried. Now, when the patients they are COVID worried, we supported the policy of the stay home and more comprehensive replies on the phone calls and social media, so that we kept them connected. We can ask them to check their intraocular pressure at a nearby facility. They don't have to come. They don't have to be exposed to the transportation. Just we kept them connected and calm. And those who are glaucoma worried and recently diagnosed, especially with a severe elevation of the intraocular pressure, we scheduled a visit, and we have some vision is that we enhanced the medical treatment during this period. We avoided unnecessary investigations. We wanted to shorten the stay time at the hospital, and then we supported the non-invasive procedures, and definitely we were not reluctant in conducting the critical interventions when needed. Then I'll just go through some of the cases to see the choices that we went through. And the first patient here is having an intumescent cataract, which is causing secondary glaucoma. And then by reviewing the recommendations of the American Academy, you can think that this patient should be managed. And then the second case is a patient with persistent angle closure glaucoma for a couple of weeks. What do we have to do, especially if the patient is one-eyed? And then a patient with pseudophakic glaucoma and intolerant to the systemic carbonic anhydrase inhibitors. What do we have to do? New vascular glaucoma. And then a patient with severe recurrent glaucoma and the pressure is high. A patient with post-keratoplasty glaucoma. A patient with juvenile glaucoma. And a patient with open angle glaucoma but underwent previous RK and the pressure was unstable and the patient was one-eyed. So those 8 examples just will demonstrate the types of patients that we have seen during this era. So the first of all, the patient with the lens-induced glaucoma and the pressure is high despite full treatment, and then you can expect that we will go for lens removal. There is no hesitation in the decision. We just have to manage this patient, and this is a clear indication to the surgery at that area. Now, if a patient with persistent angle closure glaucoma for a couple of weeks and the intraocular pressure is 45 and the pupil is dilated because of the very high pressure for that quite long period of time, we just removed the lens, and then we wanted for goniosynculitis, and then we wanted to repair the iris. So surgery is basically a lens removal surgery because this is an angle closure glaucoma beside some other maneuvers that will help the intraocular pressure control. Another situation of a patient with a pseudophakic glaucoma, and you can see an area of scarring superiorly, and the patient is pseudophakic and the pressure is not controlled, and the patient is not tolerant to the systemic carbonic anhydrase inhibitors, and thus we opted for high-intensity focused ultrasound, which is one of the non-invasive technology using piezo-ceramic crystals applied to the ciliary body, and it will treat 45% of the ciliary body. And this is the machine here. The 6 crystals will release the high-intensity ultrasound to treat 45% of the ciliary body. The point is that reviewing the results of our patient, we had a reduction of intraocular pressure of 44%, so that we are quite confident that we will help this patient in this era. Then another example of the patient with new vascular glaucoma with pressure of 50, not responding to any kind of therapy, and you can see the steamy cornea and the vessels on the iris, and then we opted for transscleral diode cyclophotocoagulation with injection of anti-VEGFs, and then you can see the patients in the OR, they are wearing masks as well. And then This is the patient with recurrent juvenile open-angle glaucoma. The patient is one-eyed, and the patient is 20 years old, and the pressure is 36. The visual acuity is 160 in this eye, so that we discussed the options with the family regarding the non-invasive procedures or the invasive, and actually we reached a conclusion to put an implant, so that we inserted Ahmed glaucoma valve for this patient during this era, and we were confident that we are trying to do the best for this patient. Now, this is another scenario of a patient with post-keratoplasty glaucoma. The pressure, as you can see, is not quite high, but the patient is using full treatment, including systemic carbonic anhydrase inhibitors. And in this situation, we had a decent discussion for the patient for the options. And then this patient actually was a consequence of phakic intraocular lens, and she got endophthalmitis. And this is the end story. And then this is a seeing eye with a vision of 618. And we will go for micropulse as the patient accepted this option. So for the micropulse diode cycle photocoagulation, we give the patient retrobulbar anesthesia, and then we place viscoelastic on the eye. And this is the probe, which is called MP3 probe. Then we mark the side that should be towards the limbus, and then we keep sweeping on the limbus. It is just massaging movement for the superior and then for the inferior limbal area. And then the sweep is usually like 10 seconds, or it could be slower than this if you wish. But again, it is just sweeping movement, and this is the micropulse technology. And this is the situation again where the patients are wearing protective masks as well in the OR. Now, the patient with recurrent glaucoma, the pressure was 28, and definitely you have more than one option, but again, we opted to go for micropulse to help this patient during this era. So if we are going to discuss the options that we have chosen during this period, you will find the following: phacosurgery, iris repair, high intensity focus ultrasound, diode cycle photocoagulation, valve implantation, micropulse, and SLT. So when we go again for evaluation, we had treated a couple of patients with micropulse, and then a couple of patients with other cycloablative procedures, and a couple of patients with phacosurgery, basically. So it seems that there is a great role for the phacosurgery alone, as we know from the reviewing the literature, and one patient with SLT. And then just a short notes on the micropulse, as long as we have used it a lot during the era of COVID-19. And then again, this is the machine, and this is the probe. And now there is a recent probe which is going to be released into the market soon. And then we mark the side that should be on the limbus, and then we keep massaging. And the point regarding micropulse is that if this is the continuous wave, there is a continuous transmission of laser during the entire treatment period. But for the micropulse, the situation is different, because the laser is chopped into micropulses with periods of off treatment in between. Let us go into a deeper information again. So there are periods of on and periods of off. So the periods of on here, it is 0.5 milliseconds where the laser is on, and the laser is off for 1.1 millisecond. So the duty cycle in total is 1 millisecond, and this will be 31%. So the duty cycle is 31.3%. So this is the application of micropulse to the ciliary body. Again, if this is just a screenshot from the machine, and you will see that the treatment is 0.5 milliseconds, and then we have the in-between off cycles 1.1 milliseconds. So this is the duty cycle. Now, if you want to calculate the total energy delivered to the eye, so it will be multiplication of the total duration multiplied by the power in watt multiplied by the duty cycle, and then you will get the treatment energy in joules. And actually, most of the treatment protocols would suggest a treatment between 112 to 140 joules as the treatment parameters for patients. And then an interesting histopathological examination, if this is the cornea, this is the sclera, and where the laser is applied here, and they have reported good changes in the ciliary muscle. The ciliary muscle, in particular, the longitudinal muscle fibers will contract, they will pull back on the scleral spur, and they will widen the trabecular meshwork, effect which is like pilocarpine effect, but actually this is basically observed when the energy level is a bit towards the 150 joules. So if you go for the mechanisms of action of micropulse, decrease aqueous production, increase uveoscleral outflow, especially during the early periods after treatment due to the induced inflammation, and then we have a pilocarpine effect. And actually, when we conducted a study to evaluate the micropulse, we obtained a reduction of the intraocular pressure of 35% on the third month when we treated 60 eyes with different glaucoma etiologies. For that, we conducted the micro pulse treatment to the children as well, and we were happy to get quite good results when we treat patients, especially with recurrent ophthalmos and difficult to treat with the standard techniques. And this is the new probe. It has a special design. It will be better, more comfortable on the limbal area, and they suggested to use 50 seconds duration so that it's less duration than what we use. We use like in usual 80 or 90 seconds. So I have those three machines in the facility. I have the micropulse system, and I have the high intensity focus, and I have the continuous wave, which I really felt were great friends during the era of COVID, which have treated a lot of patients and avoided to go through the invasive procedures. So what are the critical messages from treating patients during that period? That secondary and refractory glaucomas are more liable to be urgent cases, actually, rather than the primary glaucomas. One-eyed patients were in particular ready for accepting interventions. Uncontrolled glaucomas as well. I mean those patients were more of the glaucoma afraid or worried group, the one-eyed and the uncontrolled glaucoma patients. Then utilization of the non-invasive procedures were so helpful, including the cycloablative procedures and the selective laser trabeculoplasty. Also, telemedicine in glaucoma stable patients was actually needed, and telemedicine using even the common media around, even SMS, even the WhatsApp, and the patients wanted to feel care and wanted to feel they are connected. So, and actually at that time, we were so keen to respond comprehensively and timely on the patient's concerns, and extra safe measures to the staff and the patients all the time are definitely our primary goal. And with that, I thank you very much. And here is my email, just in case you wanted to have any question or further information, please don't hesitate to contact me. And with that, I thank you very much.
Thank you so much, Ahmed. That was brilliant, and really the work from the front line. Can you stop sharing your screen, please?
Yes, I do.
Thank you. I think if we have some questions, I have 3 of our colleagues that have raised their hands for questions. I will pass the microphone to Dr. Khaled Arafa. Dr. Khaled, you are now able to share your mic, and you are able to share your screen and your camera if you like. So if you want to pose a question. Dr. Khaled, yes, I think we can hear you. No, we lost his mic again. Let's see. Okay. So this is, unfortunately, Dr. Khaled is unable to contact us. I have Dr. Mu'mina Ahmed, who I'm going to pass the mic for. Dr. Mu'mina, do you want to address the speakers? Dr. Momena?
Can speak now.
Hello, thank you for your lectures. Can you hear me?
Yes, we can. Yes, thank you.
My question is for the three panelists. Talking about the long-term expectation that the situation of COVID will continue for a minimum of a year or couple of years. Do we have to change or to do some shift for the long-term management of our patients? I mean, I work in a multidisciplinary hospital, and it's considered a tertiary service. We have in my institution already COVID and suspected COVID patients admitted. So we limited so much. We stopped our elective practice and limited it just to urgent and emergencies. There is expected a partial opening of elective surgery within 2 or 3 weeks. Do I have to be to take to be more aggressive when my patients return back? Do I have to do aggressive interventions in case if we had another lockdown, or do I continue my practice the same way I used to do? Thank you.
I'll give you my 2 cents, and then I will ask my 2 colleagues. I do not think that as we reopen and as we start again doing elective surgery, we should not be overly aggressive, but we should also be aware that the luxury of our centers of bringing the patient every 2 weeks or 2 months is not going to be the same. The frequency of our ability to see patients is going to be reduced significantly. We will not be working with packed reception areas or waiting areas. And that means that, and the amount of sterilization and cleaning and precautions that we'll take will slow us. So if we were able to take 50 patients per doctor per day, this is going to be reduced to maybe 50% of that. So I would not advise you to be overly aggressive, but I would certainly advise you to consider that you are not going to see the patient in the usual frequency that you are used to or the patient is used to. And that will dictate certain decisions that you will have to make. It's a situation that is going to be with us, and I agree with you. It might be for a year or 2. And we will adapt and we will get guidelines, and things will get better, but it's not going to be the same. I'll take Ahmed's opinion.
I think as everything is new to us, then we are building up experiences to deal with such situations. So what happened really that in the academic areas in particular, that the lockdown is more strict than the private sector, but with the reopening of the service, I think we have to focus, and I think the system will focus as well on the safety in the first place, and then the number of patients that can cope with such greater safety. And then we need to explore the available options around us. And then, and I think if it is possible to go for non-invasive technologies, if we have those in hand, that would be good. The patients which usually we can use other, for example, when it comes to primary open-angle glaucoma, it didn't came across most of us to use SLT. Now it is the time to consider some other options, of course. And then it is the time to think that the cycloablative procedures could be applied on eyes with good visual potentials. So that I totally agree with you that we need to think in the future that we need to limit the number of the post-operative visits as much as we can.
Keith, how do you see the future after you come out of this, hopefully soon in the UK? How do you see that affecting your private practice as well as your practice in Moorfields?
It's a little difficult to predict. It's obviously going to, whether we go back to normal with no social distancing and stuff in the long term is, I presume after years that'll happen, but in the short term, it's obviously going to be very different. You know, we're going to be doing less routine follow-ups are going to be spaced out much more than before. Semi-urgent stuff is going to be done a little less urgently, would be less invasive, I think, rather than more invasive, because doing, as Ahmed's shown, doing cyclophotocoagulation or doing SLT requires considerably less follow-up than doing a trabeculectomy, and you want to keep the patients out of the clinic as much as possible until we're clear. It's very, very easy to speculate, and if you want speculation, you just have to turn on any news channel every day, and you'll hear people talking endlessly about this with no real facts to go on. So I want to try and avoid doing that, but it's clearly, UK is talking about whether they're going to ease restrictions at a time when they're still getting 600 deaths a day. They were locking down when there was less than 100 deaths a day. So I don't quite see how this adds up at the moment. And I don't see that we should, I think we just have to wait and see, to be quite honest.
It's almost a trial and error with politicians, isn't it? I'll give the mic to our colleague Ahmed Samir. Dr. Ahmed, if you have the panel for you, if you want to ask a question. If you can unmute, please. Yeah. Dr. Ahmed.
Assalamu alaikum.
Alaikum salam wa rahmatullahi wa barakatuh.
Thank you for this great lecture. My question is only asking about synechiolisis. What I'm asking about, you are professors on glaucoma that increase intraocular pressure. This is may do destruction for trabecular meshwork and the contact between the iris and the trabecular meshwork. Also, this may harm on the trabecular meshwork and the outflow of the aqueous through it. My question is, the synechiolisis, it worked, or the effect of the IOP and the effect of the contact will harm this trabecular meshwork, and it will not work anymore even we do this synechiolisis. Thank you.
Thank you very much. I would like to take as many questions as possible. So a very short answer from Ahmed and from Keith. About Ahmed first. Synechiolisis in your hand, does that work?
Synechiolisis, I would love to do with this the single pass through iris pupillary repair, because I think that will get the iris away from the trabecular meshwork in case of the pupil is persistently dilated for quite a long time. Generally speaking, I'm supporting the synechiolisis at the time being. I'm seeing very good results from that at the present time, and I think and I know there are some contradictory results in the literature, meta-analysis supporting and meta-analysis against again, but I'm supporting this technique at the time being.
Keith.
Synechiolisis, there isn't really that much hard evidence, to be quite honest, that it does anything. And certainly, it's traumatic, and I don't do it, basically.
I'll have to side with Keith on that. I totally abandoned the idea of synechiolisis. In my hands, it doesn't work. We have a question from Dr. Arshana Sood. Dr. Arshana, floor is yours.
Yeah, hello, can you hear me?
Yes, we can.
Yeah, I am working in Russell Khema, and COVID is here also, but they have started telling us to start our elective surgeries after maybe a week or two. So I was, first of all, I would really like to thank Dr. Ahmed. I came in late, so I have heard only his presentation.
Okay.
But it was excellent, and especially the diode micropulse, and he gave a very, very nice presentation and variety of cases which he has done and saved as a frontline corona warrior. Now I would just like to ask that when we start operating, or what does Dr. Ahmed use to protect himself? Are you wearing the full PPE, which or are you wearing the normal OT gown and mask and cap? Because I don't think it's easy to operate on the microscope with a face shield or goggles or too much protective eyewear. Thank you.
Thank you. Ahmed?
Thank you very much for that. And actually, everything was new to us, and even to meet the patients wearing gowns and wearing masks. And actually, I felt at the beginning a big barrier in dealing with the patients. What I actually do is just I put the mask and then I make sure that there is a plaster cap on the mask, and then I wear the gowns. Usually I don't wear gloves, but I use a lot of hand sanitizers in between the patients. And actually we use the shield protector. And then when it comes to the OR, and I think everything is like normal inside the OR, but we put masks to the patient as well as an additional protective. But inside the OR, I think we are almost the same. There is no change in the behavior or the things that we put on our face.
Thank you. Dr. Wael Tahan, if you have the mic, if you want to ask your question.
Dr. Wael, you can speak now, but unmute your mic, please.
Okay, can you hear me?
Yes, we can.
Thank you, our professors, for this valuable presentations. I want only to ask about as COVID-19 established to cause conjunctivitis and appear in the tears. Are you advised to stop doing a contact ablation for follow-up our patients, or you advise for more restrictions on doing this?
Keith, do you want to answer that?
What we've been doing is doing, IOPs with the eye care instead of Goldman and things like that. But to be quite honest, I still do gonioscopy, contact tonometry when I need to. It's not, COVID-19 is a disease. Coronavirus is in the tears. But there are bacteria in tears. We touch patients all the time. This is just more contagious, more pathogenic than most. Normal sterilization with alcohol just kills all viruses. So if you're cleaning with alcohol or a lot of soapy water, you're protecting yourself. The important thing is to be washing your hands regularly. The stuff, and there has been questions about aerosoling the tears and breathing it in. But if you've got a breath screen at the slit lamp, a large breath screen, which we have, and you're washing your hands and not touching your face, then you're safe pretty much. There's a lot of stuff out there about, unless the patient sneezes over you, in which case you should be changing the mask between, if you're going to wear a mask, you need to change it between every patient anyway.
What about air pulse tonometry? There were recommendations to completely abandon that during this period.
There was, initially there was a concern that air pulse tonometry would actually aerosolize the virus in tears. To be honest, the trouble in coronavirus situation is there's a lot of people on Facebook, the internet, on TV saying you should do this, you should do that. Most of these people don't have the qualifications to make these pronouncements, and the public is being led by all sorts of random comments. And the answer is, I don't know about the aerosolization. It sounds plausible. I don't know if it's a risk or not. But we have we've been using eye care, which doesn't blow anything in the eye. I still use Goldman. I just make sure that it's a new tip. You sterilize it. You wash your hands a lot with alcohol. Then you're minimizing risk. We are risk of getting it from patients, sure, but on the other hand, we're not working in ICU with heavily infected patients. The hospital is screening people at the door with temperature gauges to make sure that no one with a fever is getting in. That doesn't mean that asymptomatic spreaders are not getting in. Of course it doesn't, but we can minimize the contact, minimize the risk, and above all, minimize the virus load. I mean, it's all very well people saying, well, you can get it from here, you can get it from there. It's a question of how much virus do you get? Are you getting loaded with mega doses of virus, or are you getting contaminated by a very, very small amount that your body can probably deal with? It's minimizing the virus load that you might get should you come in contact with someone.
That's absolutely interesting. The air pulse situation started with one center in Europe actually advocating that, and that was followed by the ESCRS sending recommendations on that. But I totally agree with you. I think that we really never really studied that quite well, and there is no bulletproof solution. Even the eye care, I use the eye care all the time, but I'm also concerned that with the eye care, my hand is very close to the patient. The patient is basically breathing on your hand. So that there's nothing that is ideal. Anyhow, I think this has been a fantastic session. We have been followed by more than 800-900 people around the world from all over. A tribute to the quality of the speakers that we have today, Keith Barton and Ahmed Mostafa Abdelrahman. I would like to thank Jamjoom Pharma for hosting this event. I would like to thank RM and Meg, of course, for being with us and managing this in a technical capacity that has been all through really, really well done. And I thank you very much for being with us. For those actually celebrating Ramadan, I end up by telling you all Ramadan Kareem and Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu wa rahmatullahi wa barakatuh. Thank you very much.
Thank you, Dr. Tal. Thank you.